Welcome to the Ticktective podcast and video series, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your host, Leah Gertner, Director of Education and Outreach. Lyme disease is the most common vector-borne disease in the USA and is a global issue. This show includes interviews with the researchers we fund, as well as other interesting people in the Lyme scientific community. We are a nonprofit foundation based in Silicon Valley. Thanks to a generous grant that covers all of our overhead, 100% of all donations go directly to support research and prevention programs. You can find out more or donate at bayarealyme.org. Welcome, Dr. Kinderlehrer, to the Ticktective video and podcast series.
Thank you. Glad to be here.
Daniel Kinderlehrer, MD, is a nationally recognized physician with expertise in the fields of nutrition, allergy, environmental medicine, Lyme disease, and the healing of the mind, body, spirit. He co-founded the New England Center for Holistic Medicine in Newbury, Massachusetts. Dr. Kinderlehrer is the author of Recovery from Lyme Disease, the Integrative Medicine Guide to the Diagnosis and Treatment of Tick-borne Illness. He is also the author of several review articles in medical journals and in the Lyme Times. Dr. Kinderlehrer attended Tufts Medical School and is an internal medicine physician with a private integrative medicine practice in Denver, Colorado, where he treats patients with tick-borne illnesses. Your work recently and your publications have been around children and adolescents with PANDAS, which is pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, as well as PANS, which is pediatric acute onset neuropsychiatric syndrome. I'm wondering if you can speak a little bit about how you define those and how you identify patients with those disorders.
Sure. Well, initially, Susan Sweeto, I mentioned she published in 1994 a description of these kids, and a few years later, she published a description of 50 of them, and that's when she set criteria. Her criteria have sort of been subjugated because, as you said, now we talk about PANS, where PANDAS is maybe a subset. It's subsumed under PANS. And PANS, it simply allows for the possibility of lots of different microbes that can trigger this syndrome. I will mention as an aside, I don't think PANS is a very good name for two reasons. One is it's often not an acute onset. I should say PANS stands for Pediatric Acute Onset Neuropsychiatric Syndrome. It's often not an acute onset. It can be a slower or stuttering onset. And the other is it's not just pediatric population. Adults have this too. And I would love, that if we could do a large study that would demonstrate that. I actually wrote a paper and suggested we change the name to MANS, Microbial-Induced Autoimmune Neuropsychiatric Syndrome. In 2013, there was a conference where all the major players got together and they put together criteria. And it's important to have criteria for any diagnosis so that when doctors are doing studies, they know they're talking about the exact same population of people. That said, lots of kids won't necessarily meet that criteria, but they still have it. But their criteria are that a child should manifest either the acute onset of obsessive compulsive disorder or an eating disorder without any apparent medical or neurologic reason for it, plus 2 out of 7, and I'll see if I can remember all of them, but anxiety disorders, depression, anger, irritability, anger, even rage, oppositional disorders. There are tics, and choreiform movements. These are involuntary movements. They're suddenly moving their arms, hands, legs, even, and then some physical symptoms like sleep disorders and bedwetting. So those are the criteria that one needs to establish in a patient if they're going to report on a PANS patient.
So Dr. Kinderlehrer, you have published recently on findings surrounding patients who have autoimmune disorders or infections and eating disorders such as anorexia nervosa. Can you talk a little bit about those studies and how they came to be?
Well, here's what happened. Mother brought her daughter in to see me. Her daughter was 16 years old and she'd been diagnosed with anorexia nervosa. And this daughter had been in and out of eating disorder units. She was an inpatient unit, then an outpatient unit, actually 5 times back and forth, and basically just getting worse, refusing to eat. She was getting all her nutrition through a new nasogastric tube. And thankfully, she had not lost that much weight. It turns out this young woman had grown up in upstate New York. And as we all know, we Lyme literate people know, upstate New York it's a haven for ticks and Lyme disease. And she actually had quite a few tick bites when she was younger, but no known Lyme disease or no known infection. On the other hand, at 2 years old, she started screaming uncontrollably. She had a syndrome called trichotillomania, which is hair pulling. I mean, like hair pulling out. And then this gradually morphed into generalized anxiety disorder, general irritability. And when she was 14 years old, she had yet another tick attachment, did have a small rash associated with it, and then multiple other symptoms, including fatigue and cognitive problems, sore throats and swollen glands. And by the time she was 15 years old, she started food restriction. And so she was not only avoiding food, she was purging after meals. And that's when she got admitted to an eating disorder unit and diagnosed with anorexia nervosa. Well, the mother was a nurse. She was quite savvy. And she said, I don't know what else to do for my kid, but let's look beyond what they're looking for here, because the eating disorder people really had given up. And so she, on her own, had gotten her daughter tested for Lyme disease, and it was positive. And then she brought her to see me. And when I evaluated her, the interesting thing on physical exam was that she had Bartonella stria. She had what those of us in the Lyme community recognize as a Bartonella skin reaction. And this young woman interpreted the stria as stretch marks and further evidence that she needed to lose weight, which I thought was quite ironic and amazing. So we treated her with oral and intravenous antibiotics. She was on antibiotics for a total of 1 year, and she went into total remission. And that was now 3 to 4 years ago, and she has had no relapse in her eating disorder. Well, this got me thinking and wondering, how much more of a connection is there between infections and eating disorders? I was aware that it could be part of a PANDAS syndrome, and in fact, it became part of the case criteria for PANDAS as a major criteria. This girl did not satisfy the criteria for PANDAS, but she probably had it, just not in the full-blown OCD criteria. At any rate, we would have liked to have done a Cunningham panel. The family couldn't afford it, but the treatment was working. There was no reason we had to pay extra money for that, although it certainly would have been nice to publish it. At any rate, when I started doing research, it turns out there is a long history of infections causing eating disorders, including anorexia nervosa and bulimia nervosa and other eating disorders. And these are done on big population studies in places like Denmark, where they have a nationalized health system and they can track everybody. And usually those big studies, they don't describe what the infection is. They just say, well, here's people who are treated with infections or were given antibiotics. And there's some smaller reports of viruses like Epstein-Barr virus, for example. And then, of course, we have the PANDAS kids. So I thought it was very important to describe this girl. She, by the way, she also had babesia. So we were treating, and I should mention, she had mycoplasma. So think about this. She had babesia, she had mycoplasma, she had Bartonella, and she had Lyme disease. And in my experience, and I know the experience of some other practitioners, Bartonella and Mycoplasma may be the biggest issues when it comes to PANS in kids with tick-borne infections. So there we have it. I am very hopeful to be doing a bigger study on this. And by that, I mean working with an eating disorder unit, testing a significant cohort of patients diagnosed with anorexia nervosa, and getting a control population and checking their serologies for strep, for Lyme, for Bartonella, Babesia, Mycoplasma, and also doing Cunningham panels. Because of that patient, it's interesting, I have doctors sitting in with me, or at least I did before COVID, right? And so they're training with me. And when I saw this young woman, after she left, I said, wouldn't it be great if we could go into an eating disorder unit and test them? And she said, well, I happen to be medical director of a residential treatment center for adolescents with serious mental health issues. Wahoo. Basically we got permission from the center, we got an IRB, and we did a study. It was just a small study. We just took 10 kids at random and drew their blood. Now, all these 10 kids had really severe depression. They were all DSM-5 major depressive disorder. 7 out of 10 had generalized anxiety disorder. A few of them had made serious suicide attempts. One of them had ADHD. Only one of them had a known organic issue, and that person had celiac disease. Otherwise, these kids were just so disturbed with their depression and anxiety that they couldn't hack it at home. They couldn't go to school. So they were at this residential treatment center. Well, we tested them. As you may know, the interpretation of Western blot testing and immunoblot testing for Lyme, it can vary. Depending on how one interprets the testing, somewhere between 6 and 9 of these kids had evidence of tick-borne infections. Now, at that point, we were testing for Lyme, for Bartonella, and for tick-borne relapsing fever. You might ask why those 3, and the answer is because that's what Dr. Shah at iGeneX agreed to do for us. And Craig Shimasaki at Molecular Labs agreed to run 10 Cunningham panels. The most striking number was that 9 out of 10 of these kids had positive Cunningham panels. So let's talk about Cunningham panels. When we're talking about PANS, we're talking about what is otherwise more generically known as an autoimmune encephalitis. That is inflammation in the brain caused by an autoimmune reaction where our immune system is attacking our own brain. So for the sake of your listeners, I want to describe what happens with rheumatic fever. With rheumatic fever, when people get a strep throat, antibodies to the strep then attack the heart valve because there's a structural similarity between the strep microbe and the cells in the heart valve. So the immune system gets confused, so to speak, because they look alike. And the problem is an autoimmune problem. We are attacking our own tissues, but it's also an infection. It's both. And this is referred to as molecular mimicry. And what we're talking about with PANS is the same thing, but in this case, the antibodies are attacking our brain rather than our heart valves. It's again, molecular mimicry triggered by microbes. And it turns out that the first description was by Susan Sweeto at the National Institute of Mental Health back in 1994. She described kids with strep. And they were fine until they had a strep throat, and then they fell off the cliff. They developed severe OCD, anxiety, mood, behavioral disorders, declining in school, cognitive complaints, other physical symptoms like sleep problems and bedwetting. And then and they had high ASO or anti-DNase B. These are strep antibody levels. Okay. After that, that was called PANDAS, but after that, it was described that multiple other microbes could do this. Several viruses can do it, including Epstein-Barr and the common cold and even HIV, and other bacteria can do it. including particularly Bartonella and Mycoplasma. So there's a whole host, and I can tell you this list will get bigger. And in fact, it just got bigger this past month because there was a report out of Italy of 2 kids who had COVID-19 who developed PANDAS. No surprise, we were actually expecting it. So again, we're talking about microbes stimulating inflammation and autoimmune attack. And in this case, the autoimmune attack is on the brain. And what happens when those antibodies get revved up, it stimulates an enzyme called calcium calmodulin kinase 2. And this enzyme modulates a lot of learning and mood behavior, and specifically dopamine. So when calcium calmodulate, we call it CAMK2, that's a lot easier to say. When that gets activated, we have aberrations in dopamine synthesis, which we think is what accounts for a lot of the mood disorder in these kids. At any rate, now the Cunningham panel is widely available. I strongly recommend people use Molecular Labs. They have really, that's really what they do, and they do a very good job at it. Now, in terms of how accurate is this test, there have been some very good studies that suggest that it's very accurate, like 90% sensitive, and in a control population, perhaps a 10% positivity. And there have been several studies. If you want, I can go into details on that. Suffice it to say, it's a good test. It's as good as we got in this realm. So we have kids with lots of inflammation, and it can manifest a lot of different ways. And one of the ways it can manifest is eating disorders, anorexia nervosa. But here we had these 9 out of 10 kids with major depressive disorder, severe enough that they couldn't hack it at home, and they had evidence. In other words, I think it's an epidemic. Now, I can't prove that yet. I'm extrapolating from my small experience. But here's what I think's going on. I think that for epigenetic reasons, we've developed more and more autoimmune problems, and we're more and more reactive. I mean, we're seeing more autoimmune problems in general, but we're also seeing more sensitivities to food and so on. And we're seeing more sensitivity to chemicals, and we're seeing electromagnetic field sensitivities. So what I'm talking about with epigenetic problems is distinctive from genetics. So genes, as we know, they change over millennia in response to natural selection. Who knows that there is such a thing as natural anymore? But that's the basis of genetic changes. Epigenetic changes refer to changes in the proteins that sit on top of genes. That is, there are proteins that turn the genes on and off. And what happens to a parent can then be passed on to the child one generation to the next. It doesn't take millennia. It happens over one generation. And it turns out there are thousands and thousands of exposures, like the xenobiotics and pesticides they put on our lawn, to obesity and diabetes, but also trauma. I mean, PTSD. PTSD can be passed on from a parent to a child. So think about all the insults that the human population has been exposed to in the past century. We're talking about wholesale changes in our diet, where a decrease in zinc can lead to an epigenetic change that's going to affect immune system and progeny. And think of all the chemicals that are in our diet that our bodies have never known before, and think of the fact that the amount of sugar in our diet has escalated beyond what's reasonable. And then think about all the chemicals, hundreds of thousands of chemicals that we're exposed to that human population has never been exposed to before. And then add on to that the breakdown in community and extended families to single parent families and no parent families and homeless families, and the lack of security and the stress that goes with that. All of these get compounded one generation to the next. And babies are not born with a clean slate. They're born with the sins, so to speak, of our ancestors. And I think that's why we're seeing so many autoimmune problems. We see a lot of immune dysregulation in association with these insults. And now we get introduced to a microbe that used to be not such a big deal, but now it's a big deal. Now people are having major reactions to these microbes. But I should point out, not everybody. There are people who get infected with Lyme, Babesia, Bartonella. They don't get sick, or they get treated and they're fine without any problem, whereas other people get sicker and sicker with massive inflammation systemically. So what we're talking about is the seed and the soil. The seed is the bug. And yes, we are exposed more to certain bugs than we used to be. But the soil has been disrupted in a major fashion. So we're more reactive. The problem with these bugs is not that they are invading hardware the way we normally think of infections. These bugs don't, for example, invade a cell like a strep invading our throat or a staph invading a wound infection and then destroying some of the cellular network, and then there's a local inflammation to kill the bug and repair the tissue. That doesn't happen much at all with these bugs. Instead of hitting hardware, they hit software. They hit our regulatory agencies, which is our immune system, our endocrine system, our nervous system. But those, of course, are not different systems at all. It's all one big system, one huge communication network talking with each other all the time. Wow. So what we see is this destabilization phenomenon manifesting in multiple systems. Let's come back to PANDAS and, what can we do for these poor kids? It's really quite awful. These poor kids have OCD, they get agoraphobia, they're so nervous, they end up on benzodiazepines. I have a patient, actually I saw today, she has daily hallucinations and sometimes she has a psychotic meltdown when she no longer knows it's a hallucination and she thinks something is attacking her. I mean, these PANDAS syndromes are just awful. And sadly, for reasons I don't quite understand, a significant percentage of pediatricians don't believe it's real. It boggles my mind. It shouldn't, since I've been treating Lyme disease for 20 years, and we know how many doctors refuse to believe that that's real. But nevertheless, these kids are really, really hurting, and there are a lot of things we can do for them. First and foremost is to identify whatever microbes are triggering it, because antibiotics are first and foremost the first line of therapy. They need to be given carefully because Herxheimer reactions can be huge, particularly for Bartonella. We have to go slowly, gradually. And the second most common line of treatment is intravenous gamma globulin. So actually what that is it's giving antibodies that have been taken from otherwise healthy people. And as far as we know, nothing has ever been transferred by giving these IVIG, and it's usually given intravenously, although it can also be given subcutaneously. So the problem is it's hard to get IVIG covered by insurance companies. That is, it's very expensive. It can be up to $10,000 a shot every 3 weeks. So if you're a mere mortal, then you're not going to be able to afford that. And so we need to get insurance coverage, and no surprise, they keep on setting the bar higher and higher. So far, the state of Illinois has mandated that it be covered in their state. And I'm just guessing, never seen the data, that a whole lot of families are moving to Illinois to get this covered. Not dissimilar from when a lot of families were moving to Colorado for their kids with seizure disorders to get CBD or marijuana, cannabis. That said, there are studies going on. There's one that's going on now that I have gotten at least one kid introduced into that study, and he's started IVIG. Okay, but there are a lot of other things we can do. I mentioned that these kids are inflamed and they develop sensitivity syndromes. Food sensitivities can be a big deal in these kids. I've seen kids where sugar or yeast, if they have any in their diet, boom. Here's a great story. This is a kid who was probably about 10 years old when I saw him, and the parents thought they were on top of diet. They had already taken him off of gluten, they'd taken him off of sugar and a couple other things, but when they brought him to me, he had these major behavior problems, and he really did fit the PANDAS description. And I said, well, is there anything he craves? And they said, oh yeah, he could eat a whole jar of pickles or a whole jar of olives. And I smiled and I said, that's yeast. He can't get his yeast any other way. You've taken away the bread and the cake and the sugar. But he's getting it there, and you're going to have to take it away. And he's going to be very unhappy for a week or two, but then see what happens. And after 2 weeks, his behavior totally evened out. It was quite remarkable. Later on, his behavior went south again. And it turned out that a nanny that was taking care of the kid during the day was feeding him crap. And they didn't know it. That'd been going on for a few months before they finally figured out why during the week he was a crazy kid. I have at least 2 patients where corn, it kicks in their PANDAS syndrome. So it's very important to look at the possibility of food sensitivities in these kids. And while we're talking about that, many, if not most, have evidence of excessive mast cell degranulation. So again, for the listeners, mast cells are primitive white cells, and they contain up to 200 inflammatory and a few anti-inflammatory mediators. And when they get triggered and release these mediators, you get inflammation. Now, the inflammation could be just an obvious allergic reaction. It could be a severe allergic reaction like anaphylaxis, but it can cause all sorts of inflammation. It can cause headaches, and it can cause, guess what? Neuropsych symptoms too. And it can cause shoulder pain or joint pains. I mean, anything that you can think of inflammatory could be mediated by mast cell degranulation. So anything we can do to decrease that experience often helps. And that includes antihistamines, and particularly cromolyn, gastrochrome, which is a prescription generally very well tolerated, which stabilizes the mast cells so they're less apt to release their inflammatory contents. Some kids do extremely well with that. Some of these kids actually need medications to stabilize them. I mentioned my patient with psychosis, and this poor young woman, she's probably about 15 years old. She's so nice. And the poor kid, every day she has these hallucinations, but when she has what I would call a psychotic meltdown, the hallucinations take over, and she's just in a fetal position on the side screaming for hours. If they can get some Xanax or Ativan into her very early, it'll cut it down. But she's on some psychiatric medication that is helping to stabilize her, and there's clearly a role for that. There are other interventions as well for PANDAS, but I'm talking about the basic ones.
Your publication on the 10 children and adolescents who were receiving treatment for eating disorders and mental disorders, there were no controls, right? So yes, 6 to 9 of them tested positive for Lyme bacteria or tick-borne pathogens, right? Mm-hmm. But we don't know what a control would reveal. And I know that obviously funding is the problem with being able to do larger trials. Do you have hope that this will get done, or that other institutions are doing these studies who are already doing health studies on a larger scale?
Yes, very much. I have hope that this can get done. We were talking about doing this before COVID, and then obviously everything got put on hold. I was told by more than one of my colleagues that before I could apply for a grant to do a larger study, that I needed to publish the first study. And it was harder than I thought for reasons I don't understand at all. It seemed to be easier to get a case study published than a case series. I don't have an explanation for that, but I got rejected by at least 3 journals, and they were saying more or less what you were suggesting, like, well, there's no control population, the numbers aren't big enough, et cetera. Well, if one case history can make a case worthy of further exploration, I don't understand why a series of 10 kids wouldn't. And really, what's the conclusion? The conclusion is this merits further research. That's the conclusion. And so I'm very hopeful, as you suggested, I'm very hopeful that we can do a larger study.
Great. Is there anything that you would like our listeners to know, maybe to look for themselves or their children? I mean, obviously, there is the general acute onset, although you say it's not in every case, acute onset OCD, eating disorders, tics, things like that. Anything else that you would just like the listeners to know?
I'll mention a very, I think it's a really significant study, and that is a study reported in December of 2020 by Ed Breitschwer. He's in North Carolina, and he's considered one of the foremost experts in Bartonella. And he described, I think 27, I don't remember, 27 or 29 people who had the onset of neuropsychiatric symptoms. And they all tested positive for Bartonella. They tested either serologically positive with antibodies or PCR positive for DNA. There was not a control population, but 24 out of the 27 had this more or less simultaneous onset of skin problems at the same time as the onset of their neuropsychiatric problem. And they have pictures of all of these online. I recommend people check that out. Most of them are Bartonella stria. And in a previous article, they had demonstrated that biopsies of these actually showed immunofluorescent positive for Bartonella. I guess what I want parents to be thinking that if your kid is really out of control, consider the possibility that they have an organic problem. And I would look at the diet first, and I would consider these infections as well. And you're going to have to get, unfortunately, search for the right kind of physician to evaluate this, because sadly, most pediatricians are not tuned into it. Very, very sad. But in a way, the same applies to adults. I had the good fortune to just a week ago give a lecture to 200 psychiatrists who want to know, how do I evaluate a psychiatric patient for an organic disorder? That is, when do I recognize? How do I recognize that this person has Lyme, Babesia, Bartonella, rather than simply depression or an anxiety disorder? And, we need to educate them better, but I would say to the lay population out there, if there's neuropsychiatric symptoms that come out of nowhere without any obvious stress or psychological predeterminant, if there's no family history of significant mental health disorders, if this happened after an individual happened to visit a geographic area where Lyme is endemic, although I hasten to point out Lyme has been reported in all 50 states, but there certainly are areas that are much more endemic and where I would refuse to live at this point in my life, like the Northeast, the Northwest, and the Great Lakes states being the worst. Probably the Southeast coming after that. The driest areas are best places to go, like think New Mexico. And then people who are diagnosed with neuropsychiatric disorders, and they're put on different medications and they don't tolerate them and they're sensitive to them. They have weird idiosyncratic responses to the standard medications. This is when we should think, maybe there's an organic disorder underlying this neuropsychiatric disorder, and could they have Lyme disease? I just want to point out that you can have chronic Lyme disease one of two different ways. One is you had acute Lyme disease, you were treated, but guess what? You're still sick. That's labeled PTLDS, post-treatment Lyme disease syndrome, which most of us who are Lyme literate docs really abhor because it suggests that the Lyme isn't there anymore. Well, the Lyme is there, but I can guarantee you there are co-infections there as well. And that's the main reason why it wasn't successfully treated with the first round of antibiotics. The second group, I'll just mention among that first group, we're talking well over 1 million people a year. And second group never saw a tick bite or never saw a rash, never identified a flu syndrome that might have been associated with it, but developed chronic symptoms, often diagnosed as chronic fatigue syndrome, fibromyalgia, autoimmune stuff, as well as depression or anxiety disorders or some other mental health disorder, including bipolar. Well, I suspect there's a lot more of that second group who never knew they had acute Lyme but developed chronic Lyme. And I prefer to use the term Lyme disease complex. In my book, I make a case. It's not just Lyme. It's Lyme plus co-infections plus all the downstream issues we see in association with the chronic infection and chronic inflammation. And that's what I call Lyme disease complex. And they're still infected, and they also have a whole lot of imbalances. And I really think that second group who never knew they had acute Lyme, I think it's a much larger group. The only reason I say that is that's who I see in my office. I mean, I see a handful of acute Lyme people a year, but 9 out of 10 of my patients have been sick for a long time before they come to see me, and most of them never knew they had acute Lyme disease. I think there's millions and millions of people out there with the suffering from this going undiagnosed. It's very sad.
The statistic we just saw was 30% of people with Lyme disease diagnoses ever saw a tick bite. So 70% didn't understand why they were sick, and it took them many, many doctors to get a proper diagnosis. I agree with you, and that's why the Bay Area Lyme Foundation is trying hard to make sure that more people are aware about the dangers of tick bites and how to prevent tick bites and what to do after you have a tick bite. So we're grateful that you're doing the work that you're doing and that you're thinking outside the box and reacting to what's in front of you rather than what you may have learned a long time ago in med school, which probably didn't cover any of this. I mean, PANS and PANDAS wasn't even a diagnosis until recently. Stanford has a PANS and PANDAS group that will treat it, but even there, it's still not considered, very mainstream or accepted. And so thank you for fighting on behalf of those people who are not getting treated elsewhere. Thank you so much for joining us, Dr. Kinderlehrer.
You're welcome. My pleasure. I appreciate the opportunity.
Thank you for joining us for this episode of the Ticktective podcast and video series, a program of the Bay Area Lyme Foundation. You can find out more or donate at bayarealyme.org.